Hello, good morning. Please bear with me. I'm fighting a toddler cold. So I'll try to get through this, and hopefully my voice lasts as long as the slides do. So I'm Allyson Chapman. I'm faculty here at UCSF in the Division of Palliative Medicine since 2019. I'm assistant professor in the departments of medicine and surgery. So in that, I'm a little bit unusual in that I'm a surgeon. I'm a critical care clinician. And I'm a palliative care specialist. And I usually say that I'm the only one in the room, but I'm not, because Alexis is here, which is great, and one of the things I'll talk about a little bit. So as I mentioned, in a former life, I was a surgeon, and here is some proof. So these pictures are my graduation pictures for my co-residents. I trained in Texas. We all wore boots. So all of these wonderful people are awesome surgeons practicing surgery all over the country. So why am I here? And that's really a long story, and I'm happy to tell you at some point, but not today. But the short of it is that when I was a resident, I was always the one being like, why are we tracheing and pegging that 85-year-old person in the trauma ICU? Did we talk about it? Why not? And then later, like, shaking my hands, being like, it is our job. As Cara mentioned earlier, trained to teach hepatologists that psychosocial screening and support is part of their job. Talking to your patients is part of your job as a surgeon. And it was just something that just didn't sit well with me. And so when you ask those questions a lot, you earn a reputation for being a bit of a troublemaker. So that was me. But really what it did was show me that I did not have the skills that I needed to be the kind of doctor that I wanted to be. So palliative care skills, communication, symptom management, support, psychosocial and spiritual screening, many others were completely absent from my surgical training and not even a thought. And that just really needed to change. So 2 fellowships, and a few years later, here I am. It's really an honor to talk to you today about primary palliative care here at UCSF and beyond. So there is a bit of a typo here. It says primary care. It should say palliative care. But I'm going to start with a little bit of a definition, and we've talked about primary palliative care throughout many of these presentations today. But primary palliative care is palliative care that's provided by the primary team. So the cardiologists, the surgeons, the ICU team, the bedside nurse, the floor chaplains, that's all primary palliative care, versus specialty palliative care, which is the care that we all provide. From multidisciplinary, transdisciplinary teams with expertise in palliative care. So why does this matter? Why is there a distinction? Serious illness is a large and growing population, and as of 2019, greater than 12 million patients across the United States had serious illness, and more than 400,000 children. And there were only 8,400 palliative care physicians. So if you do the math, there's not quite enough palliative care specialists to take care of all the people who may benefit from it. And there will never be. As Carly mentioned, we're one of the oldest fellowships in the country, and we've trained 65. And we're one of the biggest fellowships in the country, and we're working really hard to train excellent leaders who go out into the field. But there are never going to be enough specialists to fill the need. So more clinicians need to have primary palliative care skills so that more patients can benefit from early palliative care intervention. So I'm a vegetarian, so I'm going to do a little spin on the give a man a fish parable. So if you give a man a carrot, maybe he has a snack. But if you teach a man to garden, then he can eat for a lifetime. So this is the way I really view palliative care. Our job as specialists is to provide complex palliative care to our patients, but it's also to teach everyone how to provide primary palliative care. So how do we do that? Basically, it's everything that we do here at UCSF, aside from our crown jewel of our fellowship, which is specialty palliative care training, and our ongoing CME that we all do as specialists. But everything else that we do interacting with the health system, the medical school, the residencies, the community, all of that is primary palliative care training. So specifically in the School of Medicine, we have medical students rotate with us. We have the projects that Hedia and Carly talked about. We have lectures. We all get random emails. Can you do this grand rounds? Can you come to this fellow lecture? All of that is primary palliative care education. Within the Department of Medicine, we do resident communication courses. We have lots of residents that rotate with us. We do ad hoc lectures. In surgery, I'm going to talk a little bit more about this because this is my particular niche, but we have a vertical primary palliative care curriculum. And then we'll hear a little bit more from Mike about the Mary Center and a lot of the work that's happening in the community. And there's always more. Basically, everything that we do, aside from training our fellows and continuing to train ourselves, is primary palliative care education. So who does this? All of us do this. So all of us teach primary palliative care to everyone. So palliative care specialists teach others about palliative care skills. We teach our fellows how to be experts, and then we teach our fellows how to teach other people how to have primary palliative care skills. And we also train fellows to be specialists and then serve as ambassadors for palliative care in their fields. So this slide represents a smattering of our fellows who have trained in non-traditional, as Carly mentioned, non-medicine, non-family medicine specialties. So this slide represents emergency medicine, neurology, cardiac surgery, general surgery, colorectal surgery, psychiatry, critical care. This is not an exhaustive list. These are just the most recent batch and the ones I could find pictures of on the internet that fit on the slide. And what I'm really, really proud of, that since I've been here, we've trained 5 surgeons. And I really hope that that trend continues. I think we have the most surgeons of any program in the country, and I'm really super proud of that. So you heard a lot about our fellowship, and one thing I just want to thank you guys for is continuing the trend of recruiting diversity of specialty. I think that's one of our biggest weapons in this desire to bring palliative care to more patients. So my primary palliative care niche is surgery, and one of my goals for my career and my life is really to bring palliative care to surgical patients. And the best way, I think, to do that is to teach surgeons how to provide primary palliative care in their day-to-day practice. So this is a big lift, and several other people across the country are also coming at this from different angles. But here at UCSF, we've developed and implemented a curriculum for surgical residents with the goal that no surgeon graduates from UCSF without having some primary palliative care skills in their toolkit. Again, they're not experts, and they're not going to be. That's not the point. You know, the goal is that they leave with some skills, and hopefully, even if they don't learn anything else, they at least know what palliative care is and who to call if they need more support. So we're in our 5th year of our curriculum at UCSF. It's 9 hours of didactics over 7 years. And sort of how those are divided up really depends on my yearly negotiations with the Department of Surgery and how much time they'll give me. And we teach fundamentals of primary palliative care. We teach communication, we teach symptom management, we teach what is hospice not. We give them the phone numbers for all of the palliative care teams, and really anything else that we can cram in. And, you know, I'm really proud and excited to say that with the support of the Cambia Health Foundation, we're hoping in the next few years to disseminate this work to other residencies across the country. So I just wanted to provide this visual, which is just the overview of our curriculum and how the different skills vary throughout the years. It's really designed to mirror surgical teaching, and all of the cases that we talk about in our curriculum are surgery specific. They're all cases that I or our fellows have had in their actual surgical lives, which I think makes it very relevant. So for example, we teach serious illness communication in a graduated manner throughout all of the years. So breaking bad news, you know, starts with telling a patient that they have to stay NPO and they might need an NG tube, which is very bad news to a lot of patients, all the way to, I'm sorry, your wife has had a head bleed and is no longer a liver transplant candidate. So those are just a little sampling of our cases and how we try and grow our residents over the years. We also emphasize teaching these skills to junior surgeons. So surgical training is very hierarchical, and it's also very experiential. So chief residents teach the interns how to tie knots, and then they teach them how to take out an appendix, and 5 years later, they're doing Whipples. And again, teaching their juniors how to do all of those basic skills. So we really try and teach our communication skills and our palliative care skills in that way. So we start with the basics, and by the end of the program, I'm hoping that they're not only modeling these skills for the juniors, but they're actively teaching them on wards and in goals of care discussions and just surgical practice. And that's the hope, that everyone leaves with a little bit. So the future of primary palliative care is bright, and I really feel that UCSF Division of Palliative Medicine is leading the way. We're recruiting diverse faculty in all ways, including specialty. You know, the mere fact that I'm a surgeon and I'm on faculty is rare. And I'm thankful to Steve and everyone else who's really embraced me over these 5 years. You know, we have Kwame, we have psychiatrists, we have geriatricians, we have lots of different people on our faculty. And as Carly and Hedia mentioned, we really are insistent that our fellowship classes are diverse in all the ways we can possibly think about being diverse. And then we have primary palliative care initiatives, like the surgical program, the neuro palliative initiative. Sorry, my voice is leaving me. And then we disseminate. So we do the work and then we write about it. So we have disseminated our experiences in the literature, and then we try and teach other institutions how to do what we've done. So happy to take questions, and that is all I have.